I'm Emily.
I'm Danilo.
And I'm Lucero, and we are second year dental hygiene students here at Chat State.
Alright, so hello. Today we're going to be talking about the relationship between type 2 diabetes mellitus and periodontal disease. According to estimates, 462 million people worldwide, or 6.28% of the world's population, have type 2 diabetes mellitus, and projected 700 million people will be living with it by 2045. The direct relationship between diabetes and periodontal disease is nothing new. It's been proven that type 2 diabetes and impaired insulin sensitivity produce end products which generate inflammatory cytokines and subsequently predispose individuals to inflammatory conditions like periodontitis. However, it is an often overlooked fact, and today we wanted to present some of the compelling research behind it to hopefully spread the word and change someone's life.
As dental professionals, we all are likely aware of the bidirectional relationship between periodontal disease and diabetes. We know our patients who have diabetes have decreased healing and are more prone to disease. In the last few years, many researchers have been exploring the possibility of periodontal therapy as a form of treatment to control glycemic levels. Today, we are going to dive into a few of these studies as we look into our literature review. We've used current peer-reviewed studies to choose 4 articles relevant to this topic that all led to the same conclusion, that the implementation of periodontal therapy has shown to lower HbA1c levels.
Since the mid-1960s, there has been a preponderance of evidence in studies that show the bidirectional relationship between diabetes and periodontal disease. There is almost a 3-fold increase in the susceptibility in patients with diabetes. This relationship is due to the fact that high glucose leads to formation of AGEs, which are advanced glycation end products. These affect glycogen synthesis and reduce bone reconstruction. There is also evidence that shows the periodontal inflammation can lead to reduced glycemic control and an increase in HbA1c. We will now dive into the first study of this presentation. The Pericardio conducted a study that included 62 participants that have type 2 diabetes mellitus. Participants received full mouth, non-surgical periodontal scaling during a single session. Of the 62 original participants, 44 of them were followed up in 3 months, and the results of NSPT showed a small reduction in the extent of periodontitis and gingival bleeding. Evidence also showed that there was an average of 0.29% reduction in HbA1c following SRP. So as we can see from the study, not only does NSPT help with reducing the extent of periodontitis and gingival bleeding, but it's also very beneficial in reducing a patient's HbA1c.
In the next study, the purpose was to assess the effects of NSPT on glycemic levels of people with type 2 diabetes. As you can see, there were 150 participants with type 2 diabetes and moderate to severe periodontitis. These participants were divided into 3 groups. Group 1 received SRP, OHI, and metronidazole. Group 2 received SRP and OHI, and Group 3 received no treatment as a control. Bleeding upon probing depths, CAL, and HbA1c were measured and recorded throughout the trial. Results showed a significant difference in both periodontal variables and glycemic levels at the 3 and 6 month recall intervals in the 2 groups receiving treatment. 33.3% of Group 1 and 34.62% of Group 2 saw an HbA1c of less than 7, and only 8.33% of the control group had an HbA1c level less than 7. In both groups receiving treatment, there were probing depth reductions of 0.76 millimeters to 1.35 millimeters, and a reduction in CAL of almost 1.2 millimeters. Overall, this study concluded that those suffering from type 2 diabetes and a raised baseline HbA1c would benefit from the implementation of SRP with OHI every 6 months as an overall part of their diabetes management.
And so the third study we looked at approached the relationship between diabetes and periodontal disease from a slightly different angle. It compared the impact of diabetes and periodontal status. It was a cross-sectional study conducted by a group of researchers from Saidu College of Dentistry in Pakistan. The participants were divided into 3 categories based on their health and diabetes status. A healthy group with no diabetes, a group with controlled type 2 diabetes and a group with uncontrolled type 2 diabetes. Various periodontal parameters were monitored in the span of 4 months from March 2021 through June 2021. Those parameters included CPI, LOA, missing teeth, and OHIS. The results showed that having type 2 diabetes, especially uncontrolled type 2 diabetes, found in 20.8% of Alright, so the results show that, this is bad, especially uncontrolled type 2 diabetes significantly degrades one's periodontal health. Healthy periodontium was found in 20.8% of non-diabetics, while only 4.2% in uncontrolled type 2 diabetes mellitus. Similarly, the worst case of periodontal disease was most prevalent in uncontrolled type 2 diabetes mellitus, 13.2%, and least in the non-diabetic group, 0.7%. Healthy attachment levels were most prevalent in non-diabetics, 18.8%, followed by controlled type 2 diabetes mellitus, 11.8%, and infrequent and uncontrolled type 2 diabetes mellitus, 3.5%. Highest attachment loss was most common in the uncontrolled type 2 diabetes mellitus, 6.3%, and least common in non-diabetics, 0.7%. The uncontrolled type 2 diabetes mellitus group showed the highest need for missing teeth, 2.64, followed by controlled type 2 diabetes, 1.7, and non-diabetics, 1.35. And virtually every parameter measured, diabetes scored worse than non-diabetics, and uncontrolled diabetics scored worse than controlled diabetics. This shows that diabetes does indeed play a significant role in our periodontal health, and the relationship between diabetes and periodontal disease is direct and goes both ways.
So, with all of that information, how are hygienists involved in the treatment of patients with diabetes? So, hygienists will serve to meet the needs of this particular demographic by providing quality care, so SRP, frequent recalls, all according to our scope of practice.
Alright, so does anyone know, can SRP treatment lower HbA1c levels? So, according to the current research, yes it can. SRP treatment is essentially a deep cleaning, during which the hygienist will go deep below the gums and remove all of the calculus deposits which have formed there. By removing the calculus, we remove a place for the bacteria to attach, which subsequently lowers the bacterial load and the inflammation associated with it. Less inflammation from periodontal disease will positively impact the HbA1c levels.
Alright, so how might interprofessional collaboration play a role in diabetes treatment? Hygienists not only play a role in treating periodontitis, but it's also within our scope of practice to provide oral hygiene instruction and nutritional counseling. We can also encourage routine visits for a professional cleaning.
These studies and many others supported the hypothesis that periodontal treatment could improve the HbA1c levels of diabetic patients. As we have previously discussed, we have an important role in our profession of caring for these patients with SRP treatment and more frequent recalls. By guiding them toward improved oral health, we are also guiding them toward overall health with improved glycemic levels. Thank you for your time and attention.